Celiac could be there. Irritable bowel disease, inflammatory bowel disease could be there. Crohn's disease, like cystic fibrosis.
Irritable or inflammatory? Which one you're telling?
Inflammatory bowel disease.
Okay.
Or
So if you have a child less than 2 years, if you have a young child with chronic diarrhea, what will be your differentials?
first differential will be celiac. Celiac
Okay.
disease in this
Then
case.
quick. Four, five.
Toddler's diarrhea could
Very
be
good.
there. Celiac disease, toddler diarrhea, or gastroenteritis.
Which gastroenteritis?
Um,
Chronic diarrhea. We're talking about chronic diarrhea, no? Long-standing diarrhea. Okay, so celiac, toddler's diarrhea, cystic fibrosis.
Cystic fibrosis will be there. It could be
Yeah,
there.
giardiasis.
Yes, giardiasis.
And cow milk protein allergy.
Cow milk protein allergy. Yes.
Lactose intolerance. Okay. So these differentials you're going to keep whenever your child is a young child. Okay. And if it is an older child, then your inflammatory bowel disease will add on.
Yes.
Okay. You said irritable bowel syndrome. Is it different from inflammatory bowel disease?
Yes. No, it's Crohn's disease, irritable bowel disease.
No. Inflammatory bowel disease, IBD, is Crohn's and ulcerative colitis. What is IBS? In irritable bowel syndrome, IBS. It comes in the cases of functional abdominal pain. Okay. So functional abdominal pain like IBS can also come in, older children. Okay. So this will be your list of differentials. That is why your questions should involve, important questions related to, the diet, when weaning was started, how did the episode start. Maybe it will coincide with weaning. Any aggravating relieving factors will give you, just a peek into what could be, the possibility. Okay. In toddlers diarrhea, you will get history of excessive juice intake. Okay. GIDSs, you can get a history of travel. Okay. Similarly, in cystic fibrosis, there would be respiratory complaints. There could be history of not doing a newborn screening, or delayed passage of meconium, or maybe prolonged jaundice. Okay. Things like that. Similarly, in lactose intolerance, you can have history of a prior gastroenteritis that was followed by prolonged diarrhea. Okay. That can lead to lactose intolerance. And cow milk protein allergy, what can be the features in the history that you can
There will
suspect
be
it?
allergic features like dermatitis will be there.
Very good.
Irritability, dermatitis, diaper dermatitis will be also be there.
Excellent. Okay. So presence of colic, rash, diaper dermatitis. Okay. Blood in stool sometimes even.
Yes.
Okay. So all of these could give you a clue into whether the child has a cow milk protein allergy or not. Okay. So these are your important cases. So if we start with, okay, let's start with cow milk protein. Okay. So tell me about cow milk protein allergy. So you told me the features. Okay. What investigation? What are the types of cow milk allergy?
Uh, two, uh, two types.
Mm-hmm. Name it.
Um, CMC,
Ravi. Ravi
I
members.
don't know, but I think it's IgE and IgA.
No, IgE and non-IgE mediated.
Sorry.
Okay, so it's IgE and non-IgE mediated. What will be the difference in both of these?
So
Noshin.
one can have, I don't know which one is it, but it can have anaphylaxis and
Which one you think will have?
this is eosinophil, right? So non-IgE.
No, IgE mediated. IgE means your immunoglobulins are already
Yeah.
sensitized. No, body is sensitized and can
Mhm.
react very quickly. So IgE mediated can present with severe allergic reactions, especially anaphylaxis, respiratory symptoms. Okay. Skin rash, urticaria. What about non-IgE mediated?
Non-IgE will cause vomiting and abdominal pain.
Vomiting, abdominal pain, bloody stools can be there. Okay. So most of the GI symptoms are there. Colic, being fussy. Okay. These are usually non-Ig mediated. How will you investigate cow milk protein allergy?
We will do this blood test and skin prick test we were doing in the cow milk allergy. Skin prick test, sensitization to the cow milk protein and
So
eosinophil.
basically, you have to say that cow milk protein allergy is a diagnosis that can be established on the basis of history.
Yes.
Okay, and by excluding dairy products from the diet and seeing the resolution of symptoms. Okay,
Yeah.
this is the diagnosis basically, because for a young child, generally you will, for a 1 month old, 2 month old, will you go for skin prick testing? You will not go, right? You will not go. So you will simply exclude the dairy products from the diet, okay, or put the child on special formula and you see whether the symptoms get resolved. If they get resolved, most likely the chances are of cow milk protein allergy. But later on, skin prick testing can be offered, especially for cases of Ig mediated cow milk allergy. RAS cell and RAS test and your this one skin prick testing, okay, can be done. Okay, so these are the investigations that can be done. How would you manage a case of cow milk protein allergy?
Avoiding the food with the cow milk.
Avoiding dairy products like
Dairy products, yes. Like cow milk will be avoided, and all the dairy products like yogurt, cheese, milk, all kind of milk.
okay, so if the baby is on breastfeeding, what will you do? If the baby is on exclusive breastfeeding, what are you going to do?
He will be remained on from the mother's diet. We will remove the cow.
So exclusion of dairy products from the mother diet
Mother's diet,
and
yeah.
supplementing the mother with calcium and vitamin D. This is a
Vitamin D.
to say, okay, because when you're excluding all the dairies from her diet, you have to supplement her with calcium and vitamin D, okay? Okay, and then observing the child for 4 to 6 weeks, okay? If the baby is on formula feed, then what you're going to do?
We will change the formula of the
Do
hydro. This was partially hydrolyzed
very
formula.
good. So you'll first change it to partially hydrolyzed. If the child doesn't improve, you will move on to a completely hydrolyzed formula like Neocate.
Yes.
Okay, and what is the difference between partially and completely hydrolyzed formulas?
Partially is less.
So it's partially hydrolyzed. The protein is not fully
Partially
broken.
hydrolyzed. Yes.
Whereas in fully hydrolyzed formula, the proteins are in the form of amino acids only. Okay. What else is the difference between the two? What about the cost and the taste?
Taste
Taste
is
is un, uh, better taste. Hydrolyzed is better than the completely
Yeah, partially hydrolyzed will be slightly better taste and will be palatable. Okay.
Yes.
Whereas fully hydrolyzed is difficult for the baby to take. Okay. And
Yeah.
then, of course, the cost. The fully hydrolyzed is way more expensive than partially hydrolyzed. Okay. So you have to go step up. Okay. So this will be your treatment. So if you get a case, you will mention, if the examiner is asking you about the diagnostic diagnosis, you will say diagnosis will be based on our clinical expertise, history, examination, and exclusion of dairy products from the diet. uh, any test he will ask, can you offer? Then you can tell that, skin prick testing can be offered, but maybe later. Okay. And then the treatment will, of course, be the ones that you mentioned now. Okay. Starting from partially hydrolyzed to fully hydrolyzed, or if the baby is on breastfeeding, then you will exclude dairy from the mother's diet. Okay.
Okay.
When can you reintroduce the dairy product or the milk back?
After 1 year.
Yes, generally after 1 year, we are reintroducing it back. If it was a non-Ig mediated, then the trial can be given at home. But if it was an Ig mediated reaction, the trial has to be given in hospital with the supervision of an allergic specialist and a dietitian. Okay, clear?
Yes.
Okay. So, any question in this one, Ravi?
No, it's fine. It's not.
Okay, so we'll move quickly to celiac. So, Ravi, can you tell me what investigations? So, what will be the clinical findings in celiac and presenting complaint in celiac?
Now, Dr. Ravi can go back to the recording. So I think it's good that you can have the revision again.
Recording. Which recording?
The same recordings, you can go back again. I'm recording these things.
Uh-huh.
So it's good,
Okay,
like
okay.
you
Yeah,
can
yeah,
have
yeah.
a quick revision of all the
Yes,
topics
yes,
as
yes.
well,
Yes,
okay?
yes,
Because I
yeah.
think the writing one is difficult for you guys. So at least you can listen it frequently.
Yes, yes. No, listening is better also. I'm trying to write also, but
Yeah, because
somehow
you
when
will
the book.
memorize these things, especially
Yes,
the
yes.
things which you think like you're not able to memorize, those things try
Uh-huh.
to write it down specifically because it's a good way, like the more you write the investigations, it's a good way to memorize as well.
Mm-hmm.
Okay, okay. Let's start with celiac. Tell me, Ravi.
So regarding the clinical features,
Hmm.
so usually starts after the weaning has started when
Mm-hmm.
uh, foods containing what do you call this? Gluten have been introduced in the diet, which
Okay.
leads to diarrhea, abdominal pain, cramps, colicky, and vomiting. And uh, further on, this can lead to, when it's chronic, it can lead to failure to thrive and growth and developmental problems. And
Okay.
and what else? Yeah. So
Mhm. Okay, so
many
these
other
are the
clinical.
basically features. So failure to thrive child, a child with chronic diarrhea, a child
Mhm.
with anemia not responding to iron therapy. You should all think about celiac. Okay.
Mhm.
Okay. Okay. So investigations.
So specific investigation is uh, one is exclusion from the diet, and we can see the response.
No,
And
no,
but
go to the investigations.
okay, so that is checking for TTG, anti-tissue transglutaminase enzyme, and
Antibodies. Antibodies.
antibodies,
Tissue
and
minus antibodies. What else along with? You combine it with something.
IgA, because
Serum
uh,
IgA. Yeah.
serum
Why?
IgA. Because if the child is immunodeficient, then this
Mm.
test can be false negative.
Excellent. Okay.
So
So you will do
mhm,
TTG, IgA along with serum IgA. Okay.
serum IgA,
Okay.
and this
Sorry,
is
why we will
I
do,
think
doctor, this with IgA?
Sorry.
Why we will do this with IgA?
IgA, because if the child has IgA deficiency, then the TTG IgA will not be high.
Okay.
In that situation, you have to go for TTG IgG.
mm,
So
Okay.
when you are
Otherwise,
checking actually the antibody, it is the tissue transglutaminase IgA levels specifically. So that's why you have to check the serum IgA as well with that.
okay, so you can correlate. If the child has a normal IgA level and TTG is coming normal, it means it is probably not celiac. But if IgA levels are not there, then TTG IgA will definitely be normal or low, right? Is it clear, Noshim?
Yes, yes.
Okay, so you always combine it together. Okay, okay. And if the examiner tells you, okay, he is IgA deficient, what you will do? Then you will do TTG IgG.
Yeah. Okay.
Okay, clear, Noshim?
Yes, clear, clear.
Okay, yes, yes, Ravi. Okay, so you have done TTG, where the levels are how much high you want?
I don't remember.
Okay, more than 10 times the upper limit.
10 times more
Okay,
than.
so if TTG,
Okay.
IgA levels are more than 10 times the upper limit, it seems to
Okay.
be probable case of celiac. Now you can go for anti-endomycin antibodies, okay,
Mhm.
to support the evidence, and you can also go for HLA DQ typing. Okay,
Yeah.
HLA typing as well. And if these two are also positive in conjugation with the high TTG IgA,
Mhm.
then You can discuss it with the gastroenterologist, and there's now no need for any biopsy, and you can put the child on a gluten-free diet and label him as celiac.
Mhm.
Okay. Some also say that once you have done one level and it is high, you can repeat another one. Okay. So if that is also more than 10 times the upper limit, then you go for anti-endomycin antibodies and you go for um,
HLA2 typing.
HLA typing. Okay. And if both are positive, then the child is probably celiac. Okay.
Mhm.
Okay. Clear?
Okay.
Yes.
So in what cases you'll go for a biopsy then?
If this is not
Mhm.
high, if
Yes.
tissue transglutaminase is high, but it's not 10 times higher than the normal limit,
Excellent. Very good. Okay. What else?
then we will proceed for the duodenal biopsy.
Or if and if you the clinical symptom is clinical suspicion is strong, and
Yes.
anti-endomycin antibodies are negative, okay, then you can go for a biopsy. Okay. What is the indication for gluten challenge test? And in home it should be done.
Gluten challenge.
So what is gluten challenge test?
So they have to be on a gluten diet for I think approximately 6 months. So no, no. So first we have to take gluten off the diet.
No, gluten challenge test. Na? This is because most
Ah,
of the parents, when they reach you, by the time they reach you, they've already excluded gluten from the diet. So
okay.
now, if you will do TTG, IgA, it will not be that much high.
So we have to put them on a gluten
So,
diet.
yes, so you have to re-challenge the child. Okay, so
I
you
think
have to do
actually,
a gluten re-challenge, and it is done in conjugation with the dietitian. Just I don't remember the exact amount of gluten that the child needs to take. I think
I
30
think three
grams.
grams.
3 grams.
Something.
Something is there, but it is written
Even I
very well
forgot.
in mark. Okay, so check.
Mm-hmm.
Okay, and then once you have put the child back for I think couple of weeks, then you go
Uh-huh.
for TTG,
Mm-hmm.
IgA, or a biopsy, whatever is indicated.
Mm.
Okay.
Yeah.
And also one indication for biopsy, jejunal biopsy, if the child is less than 2 years. A young child, because there are other causes also that can, lead to villus atrophy like GIDS and other things. In that situation also, a biopsy can be, helpful. Okay.
Okay.
What is the biopsy finding in celiac?
So crypt hyperplasia,
Very good.
eosinophilic infiltrates, and villus atrophy,
Plasma cell infiltrates, basically.
plasma cell infiltrates.
Very good. Okay. So, villus atrophy, partial or complete, with crypt hyperplasia and partial and plasma cell infiltrates in lamina propria.
Lamina
So, you should be knowing this. Okay.
propria.
Intraepithelial lymphocytes
Yeah,
also.
4 things are there, intraepithelial lymphocytes as well.
Lymphocytes as well. Yes. Okay. So, all of this. Okay. So, how will you manage a case of celiac? Quickly, Ravi.
So multidisciplinary approach involving everyone, and
Who
then
everyone,
we
doctor?
have
This is a history station. He wants to know who you will involve.
so we will involve the pediatrician, the dietitian, the geneticist, and
Only pediatrician.
pediatrician and endocrinologist also. I don't know. No, not
Yes.
endocrinologist. Dietitian basically, and
This is a problem with the gastroenterologist, huh?
gastroenterologist. Main
That's why
consultant I'm
everyone you
forgetting
should
every time.
remember.
Pediatric gastroenterologist. Yes.
Okay. See, this is why they mentioned the
Yeah. Even
candidate
in the last
involvement.
case, I forgot pediatric nephrologist.
Oncologist.
Here also, I forgot pediatric oncologist. Yes,
Uh,
same.
you will
Oh my
remember,
God.
inshallah. Okay. Okay, go ahead.
And then we have to put the child on a, after the diagnosis established, put them on a gluten-free diet.
Mm-hmm.
And
What's the gluten-free diet? What will you exclude from the diet?
so basically wheat and any products that contain wheat.
Three things are wheat, rye, barley, and oats.
Oh, and barley. Oats also.
Okay, oats, because when oats are milled, they will be some contamination with the wheat.
Mhm,
Okay,
mhm,
so you will exclude it. Okay, and that is the mainstay of treatment. Okay, and then you will treat whatever deficiencies have happened with
mhm.
multivitamins and
Okay.
everything. What are
Uh,
the complications of celiac?
so yes, again they can have vitamin deficiencies. So like AD, hypobetonesis, rickets. They can develop
Okay.
rickets, and shorts. They can have failure to thrive, which can lead to short stature.
Hmm.
And
Short
what else?
stature,
They can have
pubertal delay.
short stature, pubertal delay. Yes.
Hmm.
Uh,
What else?
chronic diarrhea. So psychosocial
Mm-hmm. What else?
and
Anemia, not responding to iron therapy.
anemia. Correct, correct. Yeah,
And most
anemia.
important, if the child is not compliant with the gluten-free diet, what will happen to the child in long
They
run?
have a risk for malignancies. I don't know which one. It's
Mhm.
some.
Yeah, malignancies are there. Okay, so which malignancy you will check?
I
I think
will check. Yeah.
adenocarcinomas are there of the esophagus, of the stomach. Okay, and
Mm-hmm.
so these malignancies are there. That is why when you'll counsel, you have to, maybe you have a teenager who is a known case of celiac, who's not, sticking to the to the gluten free diet. Then this point is something that will need a highlight there. Okay,
Mm-hmm.
so when you'll talk about growth delay, it can cause a delay in your puberty. Okay, and other things, it can make your bones weak, so many things. And then if you're still not convinced, then you have to tell there are certain really serious implications if you don't stick to the plan. And even, malignancy and cancers can also happen. Okay, so this is also something that needs to be there. Okay, good, excellent. Okay, okay. So celiac we discussed. Then we can come to and cow milk proteinology. We discussed IBD. Okay. So Dr. Noshin, what are the types of IBDs?
Inflammatory bowel disease, Crohn's disease, and the ulcerative colitis.
Okay. Can you give me the quick differences between the two?
Uh, they both have like abdominal pain, diarrhea,
Mhm.
weight
Mm.
loss, but ulcerative colitis, there will be bleeding, rectal bleeding will be there.
Bloody diarrhea.
Bloody
Okay.
diarrhea, sorry, yeah,
Okay.
bloody
What
diarrhea will be there.
what else? This is the physical feature, no?
Yes, yes.
Okay. Now investigations, on the basis of investigations, how will you differentiate them?
And other thing, this Crohn's disease is like from it's from in the it involves all the parts of the body. Like we studied like this.
Not all parts of the body, all parts of the alimentary canal, starting
Elementary
from
From
the mouth.
mouth
canal
to anus. Yeah, I think she wants to
from
say.
mouth to anus.
Okay.
Yes, yes.
Yes.
It involves from
Is
mouth.
ulcerative colitis?
Ulcerative colitis is confined to only colon.
Yeah, rectum specifically and can extend to the colon as well. Okay, very good. Okay. Coming to the investigations, how will you
Uh,
differentiate two?
in this, we will differentiate like the age of the child. If he will be more than 5 years old in Crohn's disease.
In both they are
Both.
usually
Yeah.
young children, no?
Yes, yes.
Or adolescent. Okay.
And we will do
Labs. I'm talking about labs. No? So if I'm
labs. We will
asking
do
labs, go to the lab.
inflammatory markers will be raised. CRP, ESR, and stool calprotectin.
It will be raised for both of them. I'm asking the difference. What about antibodies? Certain specific antibodies are there in ulcerative colitis, and in Crohn's they are different. Anti-cervici antibody is present in which one? Shumaila, I think ulcerative colitis, huh?
Which antibodies?
Anti-cervici antibodies.
This is PNK, right?
P-NK and anti-cervicin, these two different antibodies are there, na?
Anti-Saccharomyces. Anti-Saccharomyces is positive in Crohn's, and this one, P-ANCA, is positive in ulcerative colitis.
Okay,
There
so
are two
this is
types.
for antibody difference, okay? Okay, anti-Saccharomyces is positive in Crohn's and P-NK is positive in
Ulcerative
ulcerative
colitis.
colitis. Coming to the X-ray and radiology, what will be the difference? If you'll do a barium study, what will you find in ulcerative colitis? You will find that the colon is basically affected and rest of the gut is
Gut
spared.
is spared. Yes.
Okay. Whereas
Colon
in Crohn's, there can be multiple areas. That is why skip lesions will be present in Crohn's, cobblestone appearance will be present in Crohn's. Okay. Plus, in Crohn's, there is a transmural involvement. That is throughout the mucosa, there can be the inflammation.
So
That
further,
is a
like after radiology, then comes the histology. So this was the changes you can see on histology, like transmural involvement in Crohn's, and there is mucosal or submucosal involvement only in ulcerative colitis.
colitis. And whenever there'll be a transmural involvement, that disease will lead to fistula, fissures, okay,
Yes.
adhesions more. Okay.
Yeah.
So these differences you have to tell, okay? Okay, so if you want to summarize quickly, what will be the differences between Crohn's and ulcerative colitis? Both are inflammatory bowel disease. Yes, tell me.
Yes, both are inflammatory bowel diseases, but in Crohn's, it involves all the parts of the alimentary canal, but ulcerative colitis is limited to the large intestine and colon.
Okay, very good.
There will be skip lesions in the Crohn's
Don't go
disease.
to skip lesions directly.
Okay.
Think systematically. So, ulcerative colitis, there will be bloody diarrhea, whereas Crohn's will
Yes,
disease more of
more of the
abdominal pain.
abdominal pain will be
Abdominal
more
pain and diarrhea. Okay, plus the extra intestinal symptoms are more in
Crohn's disease.
Crohn's, like
Yes, there will be
like
sorry, oral epithets will be there. Gum lesions will be there in the fistulas.
fistula is this is all intestinal. You are telling me.
Extraintestinal means
UVI,
outside the alimentary
sorry,
tract.
sorry. There will
Yeah.
be uveitis in
Mhm.
this joints will be involved and the
Yeah.
skin will be involved.
And
And this
sclerosis.
erythema nodosum, erythema multiforme.
Excellent. Excellent. Okay, so this is what I want to hear. And sclerosing cholangitis also. So this child can present with jaundice as well. Okay.
Yes. Yes.
Okay, so the extraintestinal manifestations are more in Crohn's, whereas less in ulcerative colitis. Okay, ulcerative colitis presents with the bloody diarrhea. Crohn's is presenting more with the
Abdominal pain,
and
diarrhea,
abdominal
weight
pain.
loss. Weight
Ulcerative
loss will be more pronounced in the Crohn's disease.
Very good. So ulcerative colitis always involves the rectum and to some extent the colon, large colon, whereas Crohn's can be from the anus from the mouth till the anus. Okay. Then coming to the investigations, anti-Saccharomyces antibodies positive in Crohn's. P-ANCA antibodies are present in ulcerative colitis. Skip lesions, cobblestone appearance, fissures, fistula, adhesions, more in Crohn's. Okay. And coming to histology, transmural inflammation, whereas in ulcerative colitis, the inflammation would be limited to the mucosa and submucosa. Okay. So these differences you should tell very quickly because it will be asked if you get a case. Okay. Any confusion here?
No.
Okay. So if you will quickly move
Treatment, yeah.
to the so investigations already you can tell the same CBC, CRP, ESR, stool for calprotectin. Okay, then you can go for an X-ray abdomen, and you can go for barium follow-throughs. Okay, ultrasound abdomen. Okay, for extraintestinal problems, you can do further investigations like eye screening. Okay, joint pain, so you can do other investigations, so on and so forth. But mainly this will be your investigations. Okay, now the treatment. What treatment will you offer to a case of IBD?
Steroids.
You'll directly start with steroids. So first of all, you involve the team.
Multidisciplinary.
Yes.
Multidisciplinary.
Name the team you will involve, Dr.
Yes,
Noshin.
pediatrician will be there. Then a pediatric gastroenterologist will be there.
Will be there, you will not say for anything, okay? Just name them quickly. 1, 2, 3, 4, 5, okay?
Pediatrician, pediatric gastroenterologist, ophthalmologist, rheumatologist, dermatologist, dietitian.
Okay, pediatric surgeon.
Pediatric surgeon. Okay, radiologist.
Radiologist, very good. Social support, social workers, liaise with school, okay? Because it's a problem of, adolescent age group, okay?
Yes.
Okay. So what treatment you will offer?
Corticosteroids for initial presentation.
The first thing is you have to keep the child on which diet?
Elemental or polymer diet.
What is elemental diet?
We
Polymeric.
will give exclusive enteral diet for 4 to 6 weeks, right? Up to
Okay.
8 weeks, yes.
With so enteral means by mouth you will give.
Yes,
Okay, but what kind of diet you will give?
it will be elemental or polymeric diet.
What is an elemental or polymeric diet? It is just like a hydrolyzed diet, okay? Where the elements are broken down so that the digestive system doesn't have to work to absorb it, okay? Okay, and then so you will keep on elemental diet for 4 to 6 weeks, followed by gradual reintroduction of food.
Reintroduction.
Okay, what else you will do?
We give anti-inflammatories
Like
5-aminosalicylic acid, and then we can also give rectal enema of
sulfasalazine enemas, especially in cases of ulcerative colitis. Okay, what else?
Then we will give adalimumab and infliximab to the children.
Why
This
you
monoclonal
first give simple steroid, na?
Yes, steroids. Yes,
First
steroids.
you give steroids, and if the child develops any complications or is not tolerating steroid, then you can go to steroid sparing agent like azathioprine and other disease modifying agents. Okay. Okay, clear, both of you. So now this is how you're going to mention the management: elemental diet, polymeric diet, followed by a gradual reintroduction. You will start with anti-inflammatories like aminosalicylic acid. In cases of ulcerative colitis, you can give rectal enemas of aminosalicylic acid. You will start steroids, okay? And then if the child is not tolerating steroid, then you can go for steroid sparing agents, okay? Clear. What is the indication of surgery in cases of IBD?
If medical treatment is not optimal and it's not working for the patient, so
Excellent.
we will go for the surgery.
What else? 4, 5 indications are there. Na? Failure of medical management.
Failure of medical management. One will be the like strictures or toxic megacolon.
Excellent. Very good. Very good. So strictures, toxic megacolon, fistula, fissures, adhesions, obstruction. Okay. All of this would be an indication. And if any of this happens, you have to start steroids, antibiotic. You have to add on antibiotic as well.
Ciprofloxacin and metronidazole.
Okay. So that also you should remember. Okay. So that will be the management of both. Okay. Clear? Any questions in this one? Any confusion in this part? Noshin, is it okay with you?
Yes, doctor.
Okay. So the other important history that can come is that of abdominal pain. So if a child is coming with abdominal pain, what differentials you'll keep? Yes, Ravi.
So I think I have to differentiate into acute and chronic or recurrent abdominal pain.
Mm-hmm.
So abdominal pain history, right?
I think,
That you
Madhya, we
asked.
can give a case now for the history, and this meeting is about to end as well. So, Dr. Ravi, you can start taking one history for the abdominal pain. Any age group, Madhya, you can give so we can practice a bit about history.
Okay, so
Okay.
6 years old child, Ibrahim is coming with the abdominal pain. Okay, take the history from the mothers. So you can take 2 minutes. We'll share the link in 2 minutes. Okay, 2 to 3 minutes.
Okay. Okay. Okay.
Oh.
Okay, so you can prepare yourself and keep the camera open. Okay, while taking this.